Hello, everyone, and welcome to Arthritis Talks. Let's Talk Lupus. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada, and thank you so much for joining us tonight. We've come together for this event from many different places. I would like to acknowledge that the land on which I am located on which our Toronto office stands, is the traditional territories of the Mississauga of the Credit First Nation, Anishinaabeg, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis people, and I am very grateful to have the opportunity to live with my family and work on this land. Now, systemic lupus erythematosus, most commonly referred to as lupus, is a serious inflammatory disease that can involve the joints and many organs. In fact, lupus has been called the disease of 1,000 faces because it can affect people in so many different ways. We are excited to bring you today's webinar featuring Dr. Christine Peschken. Many of you will know that May is Lupus Awareness Month, and we are very pleased to bring you this webinar in partnership with Lupus Canada. Dr. Peschken will discuss the many complexities of lupus to help you better understand the disease. Now, before we get started, a few logistics. This webinar is best viewed on a laptop or desktop computer. If you have technical difficulties, please email Arthritis Talks at arthritis.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A button at the bottom middle of the screen. We will try to get to as many questions as possible during the hour that we have together. You can click on the chat icon in the bottom of your screen as well to access the chat and connect with other participants and also our chat moderator. If you find that chat distracting, you can close the chat window completely. Just click the red X icon to close out of the window. And we are pleased to continue to provide captioning of our webinars to accommodate the diverse needs of our audience, and you'll see that running along the bottom of the page. So many questions we received followed similar themes, and we'll address those first before going into a live Q&A at the end of the session. And before we get started, I want to also thank our event partners, Pfizer, United Way Winnipeg, and others for their financial support of our Arthritis Talk series. So with that, let's get started, and a warm welcome to today's expert, Dr. Christine Peschken, who is joining us today from Winnipeg, Manitoba. So Dr. Peschken, welcome. We have received a number of questions related to the basics of lupus. So let's just start with that. So could you walk us through what lupus is, who's at risk, and what are some of those early signs and symptoms?
Sure. So just thanks everybody for joining. It's really great to be here, and these are my disclosures. And now, so moving along. So first, what is lupus? Lupus is a chronic systemic autoimmune disease, and each of these words in that definition is actually important. The chronic means there's no cure, and it rarely disappears on its own without treatment. Systemic means that it affects the entire body. There are autoimmune diseases that only affect a single organ, like the thyroid or the skin. Lupus, though, is in the bloodstream and it is everywhere. It is a systemic disease. And autoimmune, that means that the body's immune system has got its signals crossed and is attacking itself because it can't tell the difference between healthy tissue and foreign invaders like bacteria or viruses or tissue that's been otherwise damaged. So that's a definition of lupus. Now, who gets it? It is close to 90% women. It is about, men do get it, but it's got a major female predominance. It is mostly seen in young people, commonly at around the age of puberty until about mid-adulthood. However, any age can get it. We do have very young children who develop lupus, and older people can still get it as well. It is also more common and more severe, essentially in all non-white populations. So that is Blacks, Indigenous people, Latin people, and Asian people all have more frequent and severe disease. And in terms of what are the early signs and symptoms of lupus, that's actually a tough question because it is such a diverse disease. Lupus can show up in so many different ways and mimic symptoms of other diseases, and it makes it really very hard to diagnose. I'm trying to advance slides here and it's try it again. I don't know if there's technical help here because I'm not being able to advance here for some reason.
Which slide do you want to be on?
There's more parts to this one, so. Oh, no, that's too far. It's also blurry. Let's see.
Slide number 9, okay?
I know it's the previous slide, but parts of it were missing. Like it had some. That, okay, that's a place to start. Should I? Okay. Yeah, my slides just got very small. So now I can't see them. I'm sorry. I will try and make it up. So there are a lot of early symptoms of lupus, fatigue or extreme exhaustion, muscle and joint pain, joint swelling, rashes, fevers, hair loss, mouth sores, and sun sensitivity. Those are all very common early symptoms of lupus. The image that I hope that you can see better than I can, because mine just went very tiny on the screen, but that is an MRI of a hand of someone who has lupus arthritis. And what you can hopefully see is on the right hand, the right aspect of the image, you can see all the bright areas that are showing inflammation around the joints. What is unique here in terms of this kind of arthritis is that you could hopefully see that the joint spaces and the outlines are nice and smooth because the joints are not destroyed. There's lots of inflammation, but not a lot of joint destruction. And that is different from a lot of kinds of arthritis, other arthritis that are seen. Now we'll see if, can we advance that one more to the rest of the, thank you. So that is just a list of all, oh, too far, of the other, thank you. The other symptoms of lupus that really can cause chest pain, Raynaud's phenomena where fingers turn white and blue, heart problems, kidney problems, brain problems, blood abnormalities, eye problems, memory issues. The list is really, this is only a partial list. So there's a lot of different things can add up to lupus, and it is one of the things that does make it very difficult to and complicated. And if we, okay, so moving on now to risk factors for lupus. Oh, good. Now we're maybe coming. I hope the slides are not very blurry for everyone else because mine are an eye test right now, but that's okay. Hopefully the audience can actually read these. So in terms of risk factors, we have to start with genetics. A person does have to have a genetic predisposition in order to develop lupus, but it's important to know that there is no single gene that will result in lupus. It is many genes acting together. These genes are different in different people, and each of these genes contributes a small amount and combines to allow lupus to develop. So those different gene combinations seen in different people are also part of why lupus looks different in different people. Also important to note, these are not defective genes. These are all of our genes. There are subtle variations in genes that we have, and depending on these variations and the combinations together with other triggers, this can allow lupus to happen. And those triggers that will act together with genes are things like infections, ultraviolet light, toxins, smoking, pollutants. These can all trigger the immune system. And we're also learning more recently that chronic stress and trauma can also contribute to inflammation and autoimmunity and can lead to the development of lupus. So to look at this another way, if you look at this diagram, along the bottom of it, you'll see genetic susceptibility because that is needed there for lupus. Then initially someone has a normal immune system, but with this genetic susceptibility, these various triggers that I mentioned, such as UV light or stress or viruses, can then interact with those genes in the immune system initially developing what we call benign autoimmunity. What that means is that if we are to do blood work or research studies during that period, we can see evidence of autoimmune disease, but the person is not unwell, has no clinical symptoms, isn't sick, everything is fine. We call that the preclinical phase of lupus. Over time, though, with additional triggers, disease does develop, and you have pathogenic autoimmunity, which can eventually result in organ damage. And this process is one of the reasons why almost everyone who has lupus will report symptoms dating back years or even months or even years prior to actually developing clinical disease.
So thank you, Dr. Peschken. That was really helpful. We have had questions about the diagnosis process. So how is lupus actually diagnosed?
So it's important to know that it's a clinical diagnosis. I try to drill this into the medical students when I'm trying to teach them about lupus, because it is really important to know that there is no single test for SLE, that in order to diagnose it, you have to take into account the symptoms that a person has, signs that are observed on physical exams, and all of the different tests, lab tests, x-rays, other imaging studies, biopsy results, and you try to put it all together like a puzzle, which again is very different from one person to the next, to try to determine whether this is lupus. And because it's these signs and symptoms, they're not specific, meaning they're not only seen in lupus. It isn't that easy always to make that diagnosis, because initially it can look like other diseases. It can also be misdiagnosed, so it is important to see a specialist for confirmation. I wanted to talk a little bit more about the ANA test. ANA, or anti-nuclear antibody, is an autoantibody that it's directed against parts of the cell nucleus. And it is often misinterpreted as a diagnostic test for lupus, meaning that if you do this test, if it's negative, you don't have lupus. If it's positive, you do. A positive ANA does not equal lupus. In medical terms, this test is known to be highly sensitive but poorly specific. What that means, highly sensitive, means that most people with lupus do have it, but poorly specific means that so do a whole bunch of other people. So the ANA can be seen in up to a third of healthy adults, and you have to interpret it together with all of the other features that I mentioned before you can conclude that it means lupus. And it's also important to know that it isn't helpful in, if you have lupus, it's not helpful in tracking lupus or predicting flares. This isn't a test that goes up or down as lupus gets better or worse.
Okay, so could you help explain what is it that makes lupus just so complex?
Sure. So these are three actual patients of mine, and this is the way they presented. The one in the middle, this is probably one of the more classic presentations for lupus. This is a young woman who presented with arthritis, joint pain, and a facial rash. This one is the classic malar rash that, if you use your imagination, looks a bit like a butterfly, and that's where one of the lupus symbols come from. On my left, at least, there's a 44-year-old man who presented with a blood clot in his lungs and muscle weakness and inflammation. And then on the other side, there's an unfortunate 13-year-old girl who came in with kidney inflammation, seizures, and confusion and psychosis. So when you look at this, on the surface of this, you might say, well, really, what do all these people have in common? And how can you even call this a single disease? Well, really, what they all have in common are inflammation and autoimmunity. The gentleman with the muscle inflammation, those bluey purple cells in and amongst the hot pink muscle fibers, that's inflammation. The rash that the lady in the middle has, that's an inflammatory rash. The joint pain is inflammatory. The squiggly green slide there, that is inflammation in a kidney glomerulus, where immune complexes are depositing on the kidney and showing inflammation. And in the brain image there, the lighter white spots are inflammation in the brain. And all of these people will have autoantibodies of various types and evidence of inflammation on blood testing. So lupus, as Sean already mentioned, can affect any organ in the body. And different people will have different organ systems affected. Fortunately, it's very uncommon for everyone to have all organ systems affected, but many people do have multiple systems affected. And this can also happen at different times, sometimes years apart. For example, a person may present with low platelets 1 year, and then a few years later develop joint pain, and the year after that come up with inflammatory rashes. And they're all part of lupus, but they're not there at the same time. So this can contribute to the complexity and the difficulty in making a lupus diagnosis as well. And not only does lupus look different in the same person, from one person to another rather, but also in the same person at different times. So a person with lupus can have periods of increased symptoms that are called flares, or followed by symptom-free periods, hopefully, or at least periods of minimal symptoms that we call remissions. This is what we're trying to achieve, at least. These flares can be very frequent, or they can be years apart, and they can be mild and not too bothersome, or very severe and life-threatening. It's really all over the place. The things that trigger flares are in some ways quite similar to what triggered lupus in the first place, including infections or stressors, UV light, pregnancy, fatigue. However, very often we can't pinpoint a single event that might have triggered a flare in a person. So when you put all this together, a wide variety of organ systems, different in different people, different in the same person over time. It really is the disease of 1,000 faces. You can see that I swiped this image from Lupus Canada, and it really is an extremely variable disease. To make it even more complicated, lupus treatment is equally complex. There is unfortunately no one-size-fits-all treatment. The different manifestations are treated differently with different drugs. And it may well be that a drug that is working well for lupus arthritis might not work for kidney lupus. And a drug that works for lupus rashes might not work for lung inflammation or something along those lines. What's more, we need to tailor the drugs that we use, both the doses and which drugs we use, to depending on how severe and active lupus is. So we may need more drugs at more than one drug at once. We might need different drugs in different doses depending on what's going on. We talk about induction treatment, where when lupus is very active, we use lots of drugs in high doses to get lupus under control. Then over time, we talk about maintenance treatment to maintain that control. So it is in this image here on this picture is meant to show all of the different molecular pathways that are involved in lupus and possible drug targets for them. This includes a lot of potential drugs in the pipeline, not some drugs that we already have, but it is some indicator of how complex lupus treatment is and will continue to be.
Okay, so you've certainly clarified why lupus is so complicated. So thinking about the future, could you share a little bit about what excites you about the future of lupus research?
So new treatments, this is actually, very exciting. For the longest time, there was a new drug called belimumab, which is listed up here now. It was approved, I think, about 10 years ago. Prior to that, there hadn't been any new drug approvals in lupus in 50 years. That is a really long time. And then belimumab was approved. Unfortunately, access in Canada is not very good yet. But recently, just within the last year or two, belimumab was approved for kidney lupus, which is a different indication than the way it was used before. And another new drug called anifrolumab. I don't know who names these drugs. I know the names are complicated and weird, but that was also approved for active lupus. And even just as exciting, not only were they approved by Health Canada, but there is a body in Canada that oversees all drugs and makes a recommendation as to whether these drugs should be publicly funded. I think you're all aware that medication costs are very expensive and it's not getting any cheaper. Newer drugs just seem to be getting more expensive. So if we don't have public funding for these drugs, a lot of people are left out in the cold and won't have access. So just early this year, this CADIF, as it's called, recommended these drugs for public funding. For us in the lupus world, this is really exciting. It means that these drugs are now available. Many private companies are already funding them. Public funding is still, unfortunately, bureaucracy is a bit slow. It's in the works. We are crossing our fingers that we will have good access for lupus patients for these drugs. And so that's exciting. Also, really, there's so many drugs at various stages in the pipeline right now. Some of them are very close. Some of them are still being studied. This is a very small list of drugs that are under study right now for lupus. It used to be that when we would go to the big rheumatology meetings, lupus was kind of, we'd go to these meetings and it was all about rheumatoid arthritis and psoriatic arthritis and this, that, and the other, because there wasn't really much going on. There was no progress in lupus and there wasn't really a lot of research, and we were sort of off in a corner somewhere. Lupus at these meetings is now front and center and probably gains at least as much, if not more, exposure than some of the more common inflammatory diseases, because there is so much happening in terms of advancement in understanding of lupus and treatment options. It's always slow. It is always much slower than we would like. When, and some of the drugs that are currently in the pipeline will undoubtedly fail, because that still happens, that they look promising, but it doesn't quite pan out for some reason. But the pace is really rapidly evolving, and I think there's no question that we're going to get even more drugs over time. And that's really important, because the other part that what we really need, and what I think is coming with an accelerating pace, is a better understanding in advancing the molecular and biology of SLE. As I was mentioning earlier in the clinical, in the other discussion, lupus is really so heterogeneous. It is so different from one person to the next. And treatment really is not been tailored. We don't have the treatments to tailor it to the individual person. We just really can do sort of generic ballpark treatment, and that's clearly not good enough. We really need a better understanding of lupus on the individual level. This fortune cookie, I love this fortune cookie image here. I swiped that one from a presentation by Judith James. She is a researcher at the Oklahoma Research Institute. She's on the cutting edge of some of the gene expression and molecular work that is being done. And this, really this fortune cookie business, that's kind of where we are now. One of the things that I think is hardest for people who have lupus is they really never know what's going to happen next. When are they going to get a flare up? Which organ is going to be effective? What's going to happen to their work life, their family life? Where's it going to go next? We just don't know. We also don't have a great feel for which treatment will fit which person. We just have generic understanding, and it's not good enough. We need a better understanding there, and there's a lot of work in progress. If you look at the graph, that's a bit of an outline what often happens to a patient. Along the bottom there is time. So at the first sort of big curve, that's when lupus first starts, often very, very active. Then we try to get it under control. And then, it may flare up again. If we're lucky, towards the end of this particular picture, it went into remission. Hopefully would go away. We can't often do that yet, but there's all these factors that we need better understanding of. We need to be able to predict who's at risk of a flare, who's at risk of disease that needs aggressive treatment versus mild disease, which drugs are going to work in which person. And there's really exciting stuff that is happening in this to allow us to do this. If you look in the graph here, there's all these pathways that we are understanding much better now, slowly but surely, in lupus. And you'll see up there all the omics, the genomics, transcriptomics, epigenomics, proteomics, metabolomics, and all of these, what influence do they have on the pathologic pathways, on disease activity, on prognosis, on risk assessment for different organs and organ damage. And as we develop a better understanding, we will be able to separate lupus patients out. It may be that down the road, we won't even call this all lupus. Maybe we'll call it lupus A to lupus B, all the way to lupus Z, who knows, or come up with other fun names for it. But there's really important attempts to try to tease this out. And if we can understand that, then we can much better develop therapy and choose therapy that is targeted to that individual, instead of this sort of generic trial and error that we currently are stuck using. So I know this looks really complicated, or maybe you think it just looks like interesting abstract art, because it could be. But and it certainly is. This is really cutting edge genetic gene co-expression molecular analysis. It's over my head. This is not work that I do, but it is actually really interesting and promising. If you look at this as a checkerboard, and if you look at all the columns of people, each one of those columns is an individual patient. Then if you look at the rows, each one of those rows in the checkerboard all the way across is a particular molecular gene cluster. Okay, this is a gene expression matrix, and this work was presented at the big scientific meeting in the US that happens every fall in Philadelphia this past year. And this is work done by Ampel Biologics in Virginia. And you see it referenced here. And what they were doing is single cell gene expression studies where they were trying to sort out molecular profiles that matched patients' symptoms. And you can see across the top, it says type 2 SLE traits and type 1 SLE traits. And those were different types of lupus symptoms. And the pink group there, the type 2 group, had a certain set of symptoms. The green, those patients that were type 1 had another set of symptoms, and the other groups were various control groups that did not have lupus. And hopefully you can see from a color coding concept, these patients looked different. So they were able to cluster some molecular gene expression together with their symptoms and start to figure out where in the molecular pathway of lupus are the abnormalities that correlate with different symptoms. That is what we need in order to try to understand, if we can understand what causes these symptoms, where the molecular abnormality is, then we can start to develop treatments that target those abnormalities. And so there's a lot of work being done in this area, and in various other areas like this, to really try and unravel the complexity of lupus, and then to target treatments that will hit those specific abnormalities. Targeted treatment often has the advantage, first of all, it's more effective than shotgun treatment, if I can call it that. Second, it often can be done with lesser side effects, because you have the effects you want with less of the ones you don't. Obviously, I don't think we're going to have no side effects. I think that's not something that we can, I've never heard of a medication that has no side effects. But certainly if we have less side effects and better effects, that's what everyone's shooting for. And that's what this sort of research promises. So I think the future for lupus is actually very exciting. This is really the same work, just shown in a slightly different way. They were working here. This is the same kind of process. And what they were doing, there was a whole large cohort of patients that had active lupus. So all of these patients had active disease. They were not in remission, unfortunately. And using these within those symptoms with different types of lupus activity, though, they were able to sort out gene clusters by symptoms. So some of these patients had severe fatigue, with their active lupus. Some had active lupus, but only mild fatigue and had other features. You can see they were able to separate these ones out again with a molecular signature. And on the other side, they were able to do the same thing here with pain, where they could show different gene expression in people who had more mild pain versus those who had severe pain. This, I think, I use this particular slide because pain and fatigue are very prevalent in lupus, and we do not have good treatment for it at all at this point. And it's kind of, the bane of most patients who have lupus. It's the bane of their existence, this unrelenting fatigue and chronic pain. So, this is along those same lines as what I was talking about. This is an attempt to try to understand what's going on. If we can further that and drill down, we are hopeful that there may be treatment for that coming down the pipeline. And I think that's pretty much.
Yeah. Thank you, Dr. Peschken. We do have many questions that came in this evening, but before I get to those, do you have any final thoughts or recommendations for our audience?
I don't know. It's complicated. I think, if ask questions of your healthcare provider, how does this apply to you? What's your lupus like versus somebody else's lupus? Try to get the most individualized treatment and answers that you can.
Okay, so like I said, we have received a number of questions. Let me try to group these in a way that makes some sense. You did talk earlier about the genetics of lupus. Could you just clarify, is lupus hereditary?
So the predisposition to lupus will be somewhat hereditary. We do see a higher risk of lupus in relatives of someone who has lupus, but it is just a predisposition. For instance, we often get asked that from our patients who have lupus. They worry about their children very naturally. But as I said, it isn't a single gene, it's gene combinations, and that person's children, her children, will be a mixture of genes that they have inherited from her and her husband. So it is a predisposition only that is stronger in someone who has a family member with lupus, especially a close family member, than someone who does not.
Okay. There's a question here from somebody who in the family where the siblings have lupus, but nobody else seems to, no parents, no grandparents, no others. So is that normal? Is that what you expect? Could you help explain that a little bit?
It's actually pretty common that it's probably more common than not that there's only one family member that has lupus, or sometimes maybe, oh yeah, my distant cousin, but that's probably a more common scenario. And the mention of the siblings are often genetically closer. I mean, they share the same 50% of their genes from their parents, versus, let's say, parents have 50% of the genes that their children do. So it's, the siblings are often more closely matched. So that's not that uncommon a scenario. And it would just be that, as said, the genetic predisposition was there, and then various triggers happen to happen on top of that genetic predisposition.
Okay. You talked about lupus arthritis a few times. Could you clarify, is lupus actually a form of arthritis?
So you will get different arguments about that. Most people with lupus will have joint pain as part of their lupus, not everyone. So, there are people who have lupus who have never had any arthritis, but probably between 70 and 80% of people who have lupus do have the joints targeted as well. And it is an inflammatory arthritis, but it is not destructive. So, some people will call it a form of arthritis. Others will say it's an autoimmune disease that has arthritis as part of its manifestations. I think it's semantics.
Okay. And can children be affected by lupus?
They can, fortunately, quite uncommon. Lupus, of course, is not, fortunately, super common. It is really quite rare in very young children. We do start to see it in the teenage years.
Okay. A number of questions along the theme of lupus and other conditions. So I'll just name a few, but the questions really are, is there any correlation or is there any association between having lupus and having, say, rheumatoid arthritis, having vasculitis, any of these kinds of diseases? Could you comment on that?
Yes. The short answer is yes, there is. A lot of, in part because the boundaries between diseases are often somewhat man-made, or person-made. Committees describe, okay, this is because it's such a complicated diagnosis. We have criteria for diseases. The criteria change as knowledge evolves. And, people don't always follow the textbook. Some people do have overlap syndromes, as we call it. They have features of both. Vasculitis was mentioned. Vasculitis is one of the features that we do see with lupus. So people may have vasculitis as part of their lupus. There are people also have overlap between lupus and rheumatoid arthritis. The one trick here is that it's not that uncommon for someone with rheumatoid arthritis to have a positive ANA test or anti-nuclear antibody. That doesn't mean they have lupus. So probably close to 20% of people with rheumatoid arthritis will have a positive ANA but don't have lupus, but an overlap is possible.
Let me pick up on that ANA question because we did receive a number of clarifying questions about that one. And I think you touched on this, but just to underline, can you have a positive ANA and not have lupus, or vice versa? Can you have lupus without a positive ANA?
Yes to both. So as said, lots of people have positive ANAs and do not have lupus. It is a very non-specific test. People have actually done this and, sampled a whole population and that don't have lupus and found very high levels of ANA test positivity. Goes up as we get older, higher in women than in men, higher in relatives of people who have lupus as well without having lupus, and positive in many diseases, chronic infections, chronic liver disease, chronic kidney disease, some drugs. All of those can contribute to a positive ANA without having lupus. So that's why it's really not a good test to make a diagnosis of lupus. It just supports it. If everything else supports lupus, this test can kind of nail that for you. The opposite is possible, but very uncommon in terms of having lupus, but without an ANA test. Yes, it happens. We all have a few patients where they clearly have lupus. We have it on biopsies and other blood tests, but they do not have a positive ANA. So it's not 100%. It is something that should make us think twice, though. The ANA testing has gotten quite sensitive. You just have to make sure it's the right test that's being done if it's negative. But it makes us think twice, but it is possible to have lupus without an ANA.
Okay, there's someone here who asked a question who has a positive ANA and a number of the symptoms that you described, but they don't yet have a positive diagnosis. So they've asked sort of what's next? What's the path they should take, presumably towards a diagnosis or not? What would you suggest?
So that's a good question. And there's two possibilities. I see, lots of people that sound like this participant in clinic because we're asked that question all the time. And first is that, lupus does evolve over time. So it's possible that someone is just on the evolution. Are they going to develop more things over time, and it becomes very clear that this is lupus. And if we think that's going on or might be, we do actually try to intervene. There are medications that you can use to try to stop that process. The other possibility is that someone might not have and might never get full-blown lupus. There are lots of, in the lupus community, there are a number of ways of describing this. Sometimes we call it undifferentiated connective tissue disease. We see signs that there is some autoimmune process going on, but it isn't, doesn't meet criteria or doesn't quite add up to lupus. Or some people call it lupet. People call it incomplete lupus, lots of names for it. And overall, it's a good thing because there's less going on. The question is what's going to happen next. And that's a tough one and has to be individually sort of followed and looked at to predict what is happening or what might happen.
You talked for a second about lupus diagnosis again, and in particular the rash and the butterfly rash that you showed a picture of early on. And the question really is, do you require that butterfly rash to diagnose lupus there, and or can that rash be somewhere else? Is it always there? A few questions about that.
Yeah, no, it's one of that rash is one of the very classic ones, but not at all. As said, there isn't a single manifestation that you have to have lupus. You know, some people have it, probably only about half the people who have lupus that have that particular rash. Also, the pictures that I showed, of course, you know, we always show pictures that are very clear. In some people who have it, it's very subtle. But you don't have to have it at all. And there are many, many other kinds of lupus rashes all over, you know, many in sun exposed areas, but not all. There's lots of different lupus rashes. So, and some people have no rash, you know, rashes are not necessarily part of lupus at all.
You talked about the challenge related to pain and fatigue associated with lupus, and we need to know more. Are there any recommendations to help patients manage that at the moment?
Yeah, tough one. And I saw that as we were leading up to this webinar, I think there was a scrolling Arthritis Society slide about all of the different non-drug avenues for pain, which those apply certainly to people with lupus just as much as they do for other forms or other forms of arthritis. And of course, the issue that we have is they're not always available to many people. For those of you that maybe didn't see that, there is everything from cognitive behavioral therapy, massage, you know, ultrasound, heat, cold, what else was in there? Journal writing, lots of different things for pain coping techniques. Exercise is high on that list as well for pain coping. And I would, you know, for that strongly suggest people seek out any support that they can in managing those things. Physiotherapy, I think, was on there. I said we don't have nearly enough resources for public resources for managing that, because chronic pain does not respond well to drugs. And, you know, often we get a lot of side effects with drugs, and, you know, we have to use them to some extent, but it's very difficult. Fatigue is very similar. A lot of those things will also help a little bit with fatigue. Many people, though, with lupus have no choice but to pick and choose what they are able to do. They simply cannot do, and they have various ways of communicating that with the people around them, and, you know, recognizing when they need to rest and how they need to arrange their day in order to get through it. And of course, sleep hygiene is always very important. Exercise, whatever they can manage, always helps with sleep as well as with pain. These are really tough issues, because they really are the bane of everybody's existence that suffers from this.
Yeah, great points about non-drug therapies. Could you touch on for a second, what are the main drugs that are being used to treat lupus?
So the main drug that we call the background drug for lupus is called hydroxychloroquine. It is it plays a big role because it has a lot of positives in lupus, and is probably the only, or one of the only drugs in lupus that doesn't affect your immune system. So it doesn't, or it does affect your immune system in a good way, but it does not reduce your immunity. It doesn't open you up to infections. It often, for many people with milder lupus, it can be enough. It is good for lupus arthritis. It's good for skin rashes. It can be good for many of the features of lupus. It helps to prevent flares, and it helps to prevent complications. So, you know, the gospel of lupus is, if you have lupus, you should be on hydroxychloroquine if at all possible. So that's kind of a background drug. And from there, drugs are added on depending on what's going on at a given time. We use prednisone, which is a real double-edged sword. Prednisone can be organ saving, it can be life saving. It works fast, and it's a very, very potent anti-inflammatory. It also has a huge list of side effects that build up over time. So as a lupologist, I spend half my time trying to get people off prednisone and half my time putting people back on it when something flares up, because it's all of our other drugs that modulate the immune system are slow acting. So if someone's having a flare, particularly a flare that threatens an organ like the kidneys or the heart, we need something that works fast, and that's prednisone usually. So we will add that in, and then also add in other drugs. Common drugs, probably the most common ones that we use are azathioprine, mycophenolate, and methotrexate. Those are probably the top three, and then cyclophosphamide for very severe life or organ threatening disease. Rituximab also, if we can access it for more severe disease. There's a fairly long list of drugs, and those other drugs, they're all immune suppressant. So they all do suppress your immune system and have a variety of other side effects as well. And we use them depending on what organ system is involved and how severe it is.
Thank you. I was going to ask you about methotrexate because we have a few people here with rheumatoid arthritis who take methotrexate, and you just answered the question before I could ask it, so thank you. A few questions here about the triggers for flares. So for example, sun, UV, etc. Do we know anything about why those things trigger flares?
So sun is, again, in susceptible people, UV light respond together with some antigens in the skin can result in problems where cells die a natural death. It's a process called apoptosis, and there's a process. I mean, our skin cells die off. They're supposed to when they're replaced. That process can be abnormal in people with lupus, and combined with sunlight can trigger autoimmunity. So we do see more evidence of exposure to autoantibodies and triggering inflammation. And so sunlight can trigger not just rashes in sun-sensitive areas, like in sun-exposed areas, I should say, but it can actually also trigger, fevers, unwellness, and whole lupus flare as well. And then viruses and infections. There's a couple of different ways there that can do it. First of all, viruses trigger our immune system. That's what they're supposed to do. If you get an infection, it's supposed to turn on your immune system so that you fight the infection. In a person with a genetic predisposition to lupus, that can also trigger the autoimmunity. So it turns on parts of the immune system that you don't want, and it can help to fight the infection, but also heats up autoimmunity, so that autoimmune reactions also happen at that time.
Okay, thank you. Okay, question here about women's health and lupus. Actually, two questions. One, what do we know about pregnancy and lupus, and menopause and lupus?
Okay. Pregnancy is complicated. For some women, hormone changes will flare lupus, but not at all for all women. Some women with lupus actually feel better during their pregnancy, and some are just, they have no lupus flares at all and nothing changes for them. And lupus pregnancies, we do have to be a little bit careful. There's a few things that can cause problems for pregnancies. One of those, as I said, the hormone changes. Some women do get lupus flares with it. Certain autoantibodies that people with lupus may contribute to pregnancy problems. There are antibodies called Ro and La. They can actually cross the placenta and cause something called neonatal lupus, where the baby develops some lupus complications, particularly affecting the heart. That is not common. It occurs in a small percentage of people who have lupus. And if we know that a woman who has lupus is pregnant, this is very carefully monitored for, so that we can intervene during the pregnancy to stop this process if that's happening. There are also antibodies associated with lupus called the antiphospholipid antibodies that contribute to miscarriages in lupus. And those also, if we know about those, they may need to be treated with blood thinners to prevent blood clots that lead to miscarriages. Pregnancy can, as said, contribute to a lupus flare. So to have a healthy pregnancy, it's actually very important to have inactive lupus. So if a person with lupus wants to become pregnant, we work hard to get lupus under control for a good number of months before pregnancy starts, and also to make sure that the medications are compatible with lupus, because most women will need to stay on medications, including hydroxychloroquine, to maintain control, because the last thing you want is a lupus flare in the middle of pregnancy. So said most women can have healthy pregnancies, but often they do require a little bit of extra attention. You end up spending more time in doctor's offices than you may choose to. And menopause. So menopause in some women, we actually see a little bit of a decline in lupus starting after menopause, presumably because hormones are less active. Some women who have lupus and go through menopause, some cannot take hormone replacement therapy if that is considered for menopausal symptoms, but many can safely take those. And so it's kind of variable in that regard.
Okay. So there's a question here about whether you can describe different stages or levels of lupus to help understand really how serious your disease is. Does that exist in the field?
That's a good question. It's a tough one to answer because it will vary over time. But there is a concept of in lupus, we talk about lupus damage. And that is permanent changes, permanent damage to an organ system resulting from either lupus or lupus treatment. An example might be kidney lupus that has resulted in kidney failure or reduced kidney function, which is called chronic kidney disease of various stages, or end-stage renal failure where a person needs dialysis or transplant. That's a permanent feature of lupus. Okay. Another example of damage might be a fracture, an osteoporotic fracture, a fracture caused by thin bones that is caused by prednisone. That's a common complication of prednisone. That also is a permanent sequelae of the treatment of lupus. Extensive scarring from skin rashes might be something. Heart attacks that are, these are all permanent things. And certainly in severe lupus, these things are more likely to build up over time. That is one measure of severity. It depends on whether or not you have organ involvement. Some people with lupus have joint and skin involvement. And although those patients may have chronic fatigue and chronic pain, which are a huge burden, they do not result in permanent damage, destroyed joints, or premature death. And so in that sense, you could say in terms of quality of life and symptom burden might be high, but prognosis for a normal lifespan is good. And, I hope it's a complicated question to answer. I hope that helps, because in an individual person, they may also go through these flares and remissions as well.
Mm-hmm. So I'm going to pick up on that as well. This might be in your future research bucket, but can you use diagnostic lab tests to help you understand or predict what's going to happen in a flare right now?
Not very much. And that is called, such a test would be called a biomarker. And right now, lupus biomarkers are not very good. If you read a textbook, you will see that a double-stranded DNA antibody and complement levels, 2 proteins, are often described as biomarkers. The problem is they don't work very well, and they don't work for very many people with lupus. Only about maybe 2/3 at most of people with lupus have a positive double-stranded DNA antibody. So if you don't have it, it's not of any use to, follow the disease along or predict anything. And for those that do, in some patients, yeah, we can see that, it's, follows along, it's going up, there's a problem coming. But in many, it doesn't work. Same for complement levels. In some patients, those are never abnormal, so it doesn't help. In, those patients where it is helpful. Sometimes they're always up, sometimes they're always normal. It's great. You have to know your individual patient, but we do not have good biomarkers. And yes, so that is high on everybody's bucket list for better biomarkers to predict lupus disease activity and flares.
Okay. A number of people have asked this important question. What kind of medical specialist should you be seeing for lupus?
At least at one point, a rheumatologist should be involved there. You may need other specialists as well, depending on, kidney specialist, heart specialist, for, a different organ specialist, a physical medicine specialist to help with pain management. Lots of different options out there. But in terms of organizing and the difference, I'm not trying to toot my own horn or the rheumatology horn here too much, but rheumatologists are really the ones that have the overview of lupus and the expertise in first confirming that diagnosis, but then overall having that overview. So not just single organ, not just one aspect, but trying to keep an eye on the whole aspect of lupus.
Okay, I'm going to ask you one more question, which I think is a question that I've asked almost every single webinar in the last 3 years. And the question really is are there any research studies around COVID-19 and lupus?
Lots and lots and lots. Yes, there are. So lots of, questions. There's several good Canadian ones ongoing right now that are looking at vaccine response, because this has been a big issue. Do people on medications that suppress the immune system, lupus type medications, do vaccines work in these people? There are ongoing studies looking at COVID outcomes. So what happens to people with lupus if and when they get COVID? And there are also, efforts undergo to try to understand, how does COVID trigger lupus? That's a common question. And we've been asking, that's not a unique question. We've asked that about, does the flu trigger, COVID? Do other viruses, or not COVID, does the flu trigger lupus? Do other viruses trigger lupus? Do other vaccines trigger? These are not new questions, and we're still trying to answer them. The difference with COVID is that there were so many people, sadly, with COVID that we may, and it's still out there, so we may be able to come up with a faster answer to that. But lots and lots of questions out there of being looked at for sure.
Okay, well, thank you so much for sharing your knowledge with us today, Dr. Peschken. We would like to take just a few moments to get the audience's feedback on today's webinar. So for those of you who are watching on Zoom, you should see a poll question come up on your screen with some options. So click on the response that does reflect your thoughts. And the responses are either, I feel more knowledgeable and empowered after attending this webinar, and let us know how strongly you agree or disagree. We'll also be sending out an evaluation form when we email the recording and the slides. So if you aren't able to access the poll question, don't worry, you'll have the opportunity to give us feedback at that time. And we really do use this survey feedback to shape our future Arthritis Talks webinars, so please do take a moment. Once again, we're grateful to Pfizer, United Way Winnipeg, and others for their financial support of this event. And we would also like to thank Lupus Canada for collaborating with us on tonight's webinar. Initiatives like this webinar are supported by our valued sponsors and donors, including those who have generously left a gift in their will. We would encourage you to learn more about how you can plan a gift to help continue essential programming like this long into the future. So visit us at arthritis.ca or lupuscanada.org to learn more. This concludes Arthritis Talks. Let's talk lupus. On behalf of all of us at Arthritis Society Canada and Lupus Canada, thank you for joining us today. Please stay well.